Hello, everyone, and welcome to today's webinar, Evolving Economics of Integrative Health, Moving from Outside to Volume to Value. My name is Tamara Moore with the Reese Group, a communications firm in DC. I will serve as today's moderator. Before we get started, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of an attendee interface. You should see something like this on your own computer screen in the upper right-hand corner. If you have joined today's webinar by telephone, please enter your PIN number, which can be found in the audio pane of your control panel. All attendees will be placed in listen-only mode. You will have the opportunity to ask questions during today's discussion. To ask a question, submit your text questions through the Q&A section of your attendee control panel. We will collect all questions and address them during the Q&A session at the end of today's presentation. If you have a question or issue with today's webinar's technology, you may type your question through the Q&A section of your attendee control panel, and someone will respond to you as soon as possible. You may also contact GoToWebinar technical support by dialing 888-259-8414. Today's presentation is being recorded and will be posted on the Leadership Program website in the coming days. I'd now like to turn the call over to today's host, Adam Cronin, Director of the Leadership Program in Integrative Healthcare at Duke University. Adam?
Thanks, Tamara. And thank you all for joining us. So today's presentation really highlights an area that every leader within healthcare, and especially integrative health and medicine, struggles with at some point, often daily, sort of the economics and the financial models that we practice within. When we were building the leadership program in integrative healthcare at Duke University, it was this particular area and this concern that led us to partner with Duke's Fuqua School of Business so that we could provide participants in the leadership program with not only leadership acumen and training, but also really ways to refine their business skills with mentorship directly from Fuqua faculty. And I just want to point out for some who may be considering applying for our fourth cohort, which begins in February of 2018, that you should try and submit your application before June 1st, and then the $100 application fee will be waived. For some of you who aren't that familiar with the program, there's more information at the website at the bottom of the slide, or you could contact the program manager, Damian Galina, and his email is also at the bottom of the slide. Next. So today I'm pleased to be able to introduce someone who I've known for many years, who has now joined us as a faculty member and is clearly a leader in the field, John Weeks. John's experience spans over 35 years in integrative health. He's been a writer, a speaker, an organizer, a leader in many different ways. And today he's going to provide some insight on the challenges for integrative health and medicine programs associated with different payment models, as well as strategies to better align programs within an organization's economic environment. So with that, I'd like to turn the call over to John. John?
Very good. Thank you, Adam, very much. It's a pleasure to be here with you all today. As I must say that when I've had a chance to come participate with the program, it's always a learning experience given the remarkable quality of the people who show up and the diverse backgrounds they bring. So I appreciate the gains I have from coming and presenting. So in this presentation, I'm going to give you a historic perspective on the topic. One caveat, if you're here to look at concierge models and some of the methods people are using in community environments, that's not going to be the focus here. The real focus of this talk is around the models and working with the systems out there. And because of that, I will be giving this historic perspective and in the context of what's been going on historically with the cost and quality crisis in regular medicine. It's a story about mission and about money, and that's always it when you're thinking about business models with healthcare. The advanced function is not working on my computer. Thank you for that, and perhaps it'll work now. So the direction we'll take will also not just be about money, but in the context of value, because frankly, that's the way the decision processes typically work, about money, and certainly, as you will see in the work towards appropriate economic integration of what were called alternative and then complementary, now integrative therapies, practices and practitioners. The value proposition is much broader typically than simply the economics, although the economics drive. If you would advance it, please. I throw this slide up there because I think it's useful for all of us in thinking about this to pay attention to our money. Our money, to pay attention to our language. The way that we work economically with the model has a lot to do with what it is that is the focus of the medical delivery organization with which we're working. It helps us as we move towards health to think about reserving the term healthcare system for those times when we are behaving as healthcare systems and not as values-based entities. If we're conscious about which we are serving, we'll know better what integration strategy might work. If you would advance, please. I'm going to give you this historic context. The three eras that I will talk on particularly are the pre-integration era, to just give you a chance to see the economic models then, because that helps us understand some of the trials and tribulations that have happened since. And then I'll flow through two of the other eras. Next slide. So the backdrop is that in this whole business of fee-for-service payment through insurance is really not that old and being as widespread as it is now. It really goes back to the Medicare, Medicaid founding of the Great Society. And as you'll see from this slide, that really shortly after that program was put in place, we were already thinking about issues related to fee-for-service with the HMO Act in '73. We were also working on value issues with our first look at interprofessionalism at the IOM, the beginning of the development of the community health centers and the biopsychosocial model, which were also posited really as responses to what was going on. Again, by '77, we were at the Office of Technology Assessment was looking at the cost problems that were happening with the advance of technology and the adoption of technology, and the crisis was built in immediately. I say this because while these developments were going forward, another development in the broad picture of U.S. healthcare was the development for alternative and complementary medicine. Next slide, please. The period in our developments went through silos. We were all advancing alone in the 80s. Next slide, please. And at that time, the general view from an economic perspective, to keep in mind, was that most of the services were outpatient. And, in medicine, that's not where most of the money is. The care was mostly very low tech, and the care was mostly time intensive. So just by their nature, if you look at them, they're not very good friends if your interest is in volume, in production. Next slide, please. At the same time, there were forms of practice that were had higher productivity. If you particularly look at the high volume chiropractic practices, some of these had labor and industry payment, had some other insurance payment to support them. You saw high volume with the advance of the ACAM doctors, the American College for the Advancement of Medicine, who often were practicing chelation. It was a big piece of a lot of the alternative MD world in the 1980s, which could be high volume with the number of patients you could treat at one time. Many of the practitioners actually enhanced their practices and still do with product sales. And then, of course, there was the last way that people did well, which was through making themselves well known in their communities or nationally. If you look at this group, one of the things that it has in common is that most of them are not the easiest for mainstream delivery organizations to digest, and have not been on the front end of the business models. So again, the places where you could make the most money, just being blunt about it, back in the 80s, early 90s, were not, in fact, areas that were that conducive to the integration process. Next slide. At the same time, there were economic dimensions to, I would say, the claims. I call them the Hottub Claims because back then we used to talk about where are you best. It was pre-NIH activity and involvement. There wasn't that much research going on in the U.S., and so we were all kind of left on practitioners talking about where their practices did best, where they thought their value was. And this is a kind of synopsis of where it was. What's important for our theme here is if you ask these folks about what potential value the system might have, you see this list here at the bottom with, again, diminished use of pharmaceuticals, perhaps lowering adverse events, perhaps not needing certain procedures or surgeries, a general belief that appropriate use would lead in lowering costs. Again, this is a belief-based assertions. Again, as a group, if you look at them and what you're interested in is volume, you can see inbuilt here some of the struggles that we've had since and some of the conflicts that we've had since. Okay, next slide. So we move into this next phase. Next slide, please. What I've learned to call non-integrated integration. It began, most of you will know, with the publication of David Eisenberg's study that alerted all the major stakeholders that a lot of adult Americans were using some forms of what he called unconventional medicine, and truly all of them, whether it was politicians, insurance companies, hospitals, employers, began to wake up to the fact that this was a living, breathing entity among them, and perhaps not just to be cast aside as fraud and quackery, which was typically the case back in the 80s. The interest was in market, most significantly. Next slide, please. So you look at their motivations, and there was, to respond to the consumer interest, it was actually an era of the beginning of real competitiveness and advertising competitiveness between medical delivery organizations. So the response to, there was a desire to respond to consumer interest that was both about the consumer, but it also was about, having a leg up on your competition. So it was about money and financial model as a sort of marketing lure. We saw this in actually early investigations with cardiology and oncology, big ticket items where actually there also could more easily perhaps be a little extra money generated to add something addition. Interestingly enough, the integration process began, as you can see, with this interest that's deep inside of tertiary care, which is again as far removed from where the consumer interest in alternative and complementary medicine had begun, which was out in the community. But the models that were being used, and these are important and these are enduring in their lessons at that time. In insurance, what we've learned to call them, they're carve-outs. So typically the insurance company, instead of sort of covering chiropractic as part of its general plans for covering back pain would go to a separate company, a managed CAM company we used to call them, and they would be contracted to develop a provider network of chiropractors or of acupuncturists, naturopathic doctors, massage therapists, etc. They would develop these networks, they would credential the practitioners, and then the insurance company would typically go and sell a rider, they call it, onto the insurance policy for a separate amount of money that would be passed through with a piece taken off to the CAM management company, and it would be separately managed outside of the basic medical service delivery. If you can picture that, so we're beginning to have something that might look like integration, meaning a patient will say, well, look at my insurance company covers acupuncture. So they have it in their plan, but it's actually not integrated at the level of the medical director saying, how do we best use this, have an insight as we think about what's the best care for back pain. Similarly, on the delivery side, what we tended to see then was also an effort to respond to the consumer interest, and I should add, respond to the interest of the physicians typically inside of the organization who had interest in integrative practice, in complementary alternative medicine, mindfulness, or acupuncture, maybe even had some training, but had been quiet about it until Eisenberg. As these folks came forward, they wanted to respond to them, and what they typically did was set up these separate, non-integrated, integrative facilities, typically off-site, quite separated, so you weren't even deeply involved in the medical dialogue inside the organization. You weren't necessarily connected very deeply to other specialties. In fact, in the early days, it was kind of intentionally set up so you wouldn't have to confront the depths of the polarization that existed. Next slide, please. So these next two slides I'm going to share with you, they really were examples of how many of us kind of learned along the way. Coming from the 80s, I had this kind of assumption that insurers would be our new best friends, and because there was, the Hottub claim that these therapies and practitioners could save money. And so wouldn't insurers be our best buddies if only we can get them to open their doors? And, for instance, here in Washington State, where it's my base, the political leadership passed a law that required all health plans to use every category of provider. This opened the doors, It opened the doors quite widely. And to a dialogue, I personally got to be quite involved through working with the insurance commissioner and bringing together these practitioners from these professions with the insurance, major insurance companies. Is a 2-year-long process. But what we didn't really know behind that, or didn't fully appreciate, is that the basic business model of insurance, if you look at the chart here, is not incented to save money. It actually works under kind of a dual incentive structure. Once they have the premium for this year, then they'll try to control costs for this year. But if costs go up, as indeed they have from 1983 to 2013, as I show, the percentage of the premium that the insurer is allowed to keep, and that's for marketing, for administration, and actually, if you look at it also includes their profit margin. And this is max. In fact, back in the day, this number floated up to 28% to 32%, was sometimes much lower at 10 or 11%. But and that was, I remember, HMO here in Seattle, the way I worked with was working at 11%. But regardless, if you look at this and ask yourself as a shareholder, say, of a large insurance company, would you rather have 20% of $16,000 or 20% of $3,500? It's kind of it's a tough factoid to take in, but a very important one as we think about insurance in this business of figuring out our economic model. Next slide, please. Perhaps more difficult to accept certainly was for me, I think for many of us, because many of us are closer to the delivery side here, is that the fundamental incentive structure for most of U.S. medicine to this very day, and virtually all of it back in '93, it was what the Clinton health reform was trying to shift, is based on volume. And so if you look at the top bullet here, when you sit down at the beginning of the year and you want to know what your staffing should be, you want to know what your business is going to look like, you make a guess at how many cabbages, how many angioplasties, how many of every different type of procedure and surgery you're going to do, and you have an idea of what a good year is based on performing that many or more. If, say, Dean Ornish then walks into your room and he says, as he did, and I will share a bit on this later, with an insurer partner actually, as he did, and says, you know, I can keep you from needing to do these procedures. You've got what is, by definition, perverse incentives operating. If you're saving money, you're not necessarily immediately creating friends. If you're diminishing the use of procedures, you're creating hardship on the people who perform those procedures. If you're diminishing revenues, you're changing the nature of the practice. Again, these were learned on the streets by us, and against, I think, some naivete. And I don't want to say that in all cases, either with the insurers or healthcare delivery, as we well know, is this the primary motivator. But to the extent that it's so, there's a problem if your value is in actually saving money. Next slide, please. So again, if you go back to the Hottub Claims, go ahead with the next slide. You realize that you've got a problem with the alignment of incentives, and it brought forward this question that kind of dawned on me in this process, that to the extent there was a lot of business activity in complementary alternative medicine in the 90s as this came forward, and people were jumping on it. They were starting up these CAM networks, starting up clinics, trying to venture capitalists trying to run networks of integrative clinics across the country. And it began to become clear that what the big money, the real economic value of these therapies and practices is not in production, in generation, but rather it's to the extent we can find it, it's in saving money. Go ahead, next slide. One of the interestingly enough, and I won't go into this slide. I understand you're going to be able to get these later on, but there were a lot of surveys that came out in that period of time when people were just trying to get a sense of the landscape. There were surveys of employers, surveys of insurers, surveys of consumers, patients, physicians, and interestingly enough, you relatively routinely found between 25 and 40% or so, without knowing anything, would say, yes, I believe that if we do more integration of these folks, that we will find ways to save money. So there was a strong plurality at the outset that thought that perhaps this postulate that the money may be in saving money would hold true. Next slide, please. So this is the Ornish story. We were coming up with some data back then that supported that perspective. Certainly the most significant and the most visible was the work of Dean Ornish and his group around reversing atherosclerosis. He then put together a program, ended up partnering with hospitals. One of his major partnerships was with Highmark Blue Cross Blue Shield, a woman there named Anna Silverman, who was with their wellness program. Adam will remember her from some of our integrative medicine leadership summits back then. They became great advocates for this program, which they, in their own studies, as they testified before the White House Commission on CAM policy in 2001, that they were found an average of 16,000 savings per user of the program. And they actually concocted a program that was a partnership with Dean. They called it Lifestyle Advantage. The plan was to roll this out across the country. They, in fact, thought that the Medicare coverage was more close at hand than it proved to be. It didn't happen until just a few years ago. But the other side of this was, as they worked and spent money trying to roll it out, they simply had a hard time finding the teams of delivery organizations whose cardiology groups wanted to go along with and promote this program inside. And so after a couple of years of hard promotion nationally, they dropped the program. But still, the factoid is there. The savings were there. The potential savings were there. Next slide, please. Another interesting pilot that came out of that time, and I'll be referring to the same group a little earlier, though they have changed their name from Alternative Medicine Integration to Advanced Medicine Integration Group. They tried a managed CAM program through HMO Illinois. So it was a carve-out program, but they had an opportunity to manage a subset of the HMO Illinois population in an integrative primary care environment there. In fact, it started off initially, they have broad scope chiropractic law in Illinois, started off there. They expanded to have some integrative MDs possible. It was never very large. Honestly, I've never fully understood why they couldn't create more uptake of this with other insurers, but rather remarkable changes in, as you see, hospital admissions, hospital days, pharmacy costs, outpatient procedures, all down by over 50%, and a great, I think the best data point, I'm sorry, is from a slide I made first. So forget about the bottom there. I need to correct it. But anyway, they found quite remarkable savings. And this study was actually published twice in the Journal of Manipulative and Physiological Therapeutics. Next slide, please. A direction. This direction was not supported as much as many of us would have liked to have seen by the NCAM, as it was known back then, now the NCCIH. While Congress asked the agency to, up top, to assist us in understanding the best value of these therapies, modalities, systems, and disciplines was the term they used repeatedly, in the delivery of regular care. charge from Congress, which was, in touch with citizens, in touch with insurers, and hospitals were trying to figure this out. Unfortunately, that charge went inside of NIH that doesn't tend to value financial outcomes or outcomes in general as much. And you see right here, I've not seen these data since 2006. They've gone up some, but they're still a very low minority. And because of that, we actually have a lot less information now in this value-based era about how there might be savings through this specific uptake of this kind of integrative pain program or broader use of acupuncturists or broader use of chiropractors. It's not been a priority, so we know less. There's still time to urge NCCIH to move in this direction. Those of you who are researchers will know it's not typically the strength there. On the other hand, it is clearly what these kinds of outcomes were clearly what were in the mind of Congress when they charged the agency and began to fund it. Next slide, please. One of the directions that I went with this, next slide, please. Can you hear me there on the slide? There we go. Good. I encountered a fellow named Sean Sullivan, who ran the Institute for Health and Productivity Management. He'd been a leading employer, was with the National Business Coalition on Health in the early days. And as we got to know each other and I described some of these issues with insurers and hospitals in terms of incentives, he said, oh, maybe we should be thinking about integration from the demand side. Fun language, but what he's talking about there is if you look at the interest of the employer and or the government agency, and of course consumers are on the demand side, they haven't got this interest in more. They frankly have the interest in less, and so therefore there might be some greater alignment as a community. The integrative health and medicine field has not really worked this as deeply as it can. Ken Pelletier has tried to do so. But if you look at it, two key points to bear in mind. One of them is in the triangle there. If you're looking at the factors that are the most costly to an employer, when they look at the global costs of health, the great big blue section on the left side of there is what they call presenteeism, which is it's a productivity-related factor that means basically people are coming to work, but they're not being as productive as they could be. If you look at the chart on the right, though it's pretty hard to read, if you look closely, you can see that many of these kinds of issues that are linked to productivity loss are areas where there's growing research and certainly continuous hot tub claims that integrative therapies can be useful. Things like allergy, things like depression, anxiety, some of the tiredness, basic issues like that, that where there are strengths are areas where you can actually move the dial for employers nicely. Next slide, please. The other direction that I think Samueli Institute and Wayne Jonas and his group took the lead in trying to frame up was more broadly framing the economic argument as a values argument for the medical delivery organizations, for hospitals. If you look at the top, I recall when the first people started saying, hey, if we actually have CAM therapies available and we can both allow our nurses, for instance, to be doing that, and second off, perhaps give them access to the mindfulness or acupuncture or massage services. Look at the impact we might have on nurse retention and look at how much that costs. So we're moving the value proposition. It's still economic, here, but it's not specifically about the cost of the service and the benefit particularly gained. Again, the broader framing in the context of value. Next slide, please. So we move now into the era that I'll conclude my comments talking about, and that's this volume to value. There's a lot of talk about it in medicine and a lot of efforts to move there. We haven't shifted that much of what we're doing yet. Next slide, please. But it's created some real opportunity. I'm going to move through these again. This movement to value, I'm not going to give you details on it. Next slide, please. But it really harkens back to the Clinton reform. It includes the development of evidence-based medicine. It includes the discovery of how many people, frankly, are being armed and killed through the regular practice of medicine, from the IOM reports, the Crossing the Quality Chasm efforts in 2001. Next slide, please. Next slide, yes, thanks. The way it's framed up now is the triple aim, and since then the quadruple aim. And these are to enhance patient experience. The fourth aim is to enhance practitioner experience. So you can see those two things that useful in nurse retention are part of the quadruple aim, and the other two are lowering per capita costs and general population health. What this values movement done is it shifted the equation, you see, as you're looking at the value of lowering costs. If you're walking into the patient experience, which has always been high in integrative health, you are walking into a much friendlier environment for potential value. Next slide. And you can go to the next. These two slides are just to share with you that the people in regular medicine are beginning to reframe what they're doing here. They're beginning to use this language. Go ahead with the next slide. They're beginning to use this language of healthcare, speak of the difference between production and health creation. Again, it's language that's been around the integrative health community since it began to define itself. Next slide, please. And the key, I think, articulator of this was Ken Paul's Adelina, where there was a major integrative health initiative. And he said in this 2011 talk that, you know, where he originally saw integrative health in a fee-for-service environment as being a cost center, he was now underneath the Affordable Care Act, the movement to value, beginning to see it as an asset in his planning. Next slide. So some of us began with this project for integrative health in the Triple Aim. Next slide, please, to begin to explore this overlap of values between, next slide, please, integrative health and we're attempting to accomplish. We engaged a survey with both of the education consortia involved to actually check in on perception of the leaders of the integrative centers who were involved with the behavioral integration medicine in America, integrative medicine in America study that's pictured here. Next slide, please, to see whether the Affordable Care Act had changed context, had created more opportunities for them. Those slides are available through the ACIH site on the Project for Integration Health and Triple Aim if you want to look into it. But generally, there was a strong perceived alignment with the Triple Aim values. We saw there was something like 40% who actually were getting more dollars set to their programs. There was a perception that there were more specialty groups that were beginning to invite them inside their dialogue to help them with the problem set. There was a belief that the system was beginning to look to them as perhaps having value in their efforts to next slide, please, to enhance health and to meet some of the AAA goals. So next step, excuse me, next slide, please. My time's running, so I'm going to move kind of quickly here. Anyway, the details here of that sort of cost, I invite you all to go to this site. We've aggregated about 30 studies there on cost because it's core. There are a good deal of data available. Next slide, please, that you can access. And then there are also some data there on the site about some of the models, one of which I'll talk about in a moment here, that are trying to create integrative patient-centered medical homes, for instance, and provide also some of that patient experience, patient engagement data. Next slide, that can help your case making on the value side. Here's one example. It was philanthropically funded and continues to be in part, but it's an integrative, fully integrative patient-centered medical home in Maryland, and they've recently reported out some of their findings relative to the other PCMHs in their ACO. And as you can see here, there are some signs that they're doing actually quite well relative to their peers in terms of a number of these cost-saving indices. Next slide. This is the same group that I mentioned earlier. They're, however, here working in Rhode Island. This is an integrative nurse, a holistic nurse-based program managed through a nurse, but they've got chiropractic, acupuncture, there's mindfulness involved, there's massage therapy involved, together with primary care doctors. And again, with this very costly group of Medicaid patients they've been managing, again, remarkable early outcomes there. I interviewed them not long ago. They are saying that they're in a lot of dialogues with people who are interested in that model. Again, let's see what the uptake is going to be. Next slide. A note that I felt like I had to share around the economics because it's in everybody's mind, and this is kind of legacy, at least in the one case, of a model that was started up in the non-integrated integrative medicine era, which was the Continuum Center in New York City, one of the beautiful spots. They've actually grew to being beyond break even in a site. Just before they were shut down, they made a decision the 2 years before that to expand the facility after actually very, very lengthy exploration and how their expansion and their business model can be best described to the system, and frankly looking at the generation of upstream, the people that they're pulling into the system who are attracted to their center, who they then are referring people into the system for more costly procedures, surgeries, care. Unfortunately, they ended up Continuum in a merger where they were the smaller partner with Mount Sinai, and it happened to catch them at a moment where financial analysis basically said, you're a money loser. It was, they built out, but they hadn't yet built up the practice to fill out the new space, and the decision was made with the new folks to shut down this gym there in New York, which had been started through philanthropy and, as I said, moved towards a break-even balance sheet, but then had moved into the red to expand. The other sad story there, the other was another similar story where the Arizona Center for Innovative Medicine in Tucson had built out a clinic with a partner in Phoenix. It wasn't their own health system because of the laws in the state there, but it was going to be the place where they planned to prove the model, the cost-saving model of integrative care in partnerships with large employers in the Phoenix area. And again, the Arizona Medical Center formed a partnership with Banner Health, and Banner was not interested in it, and the smaller partner in Phoenix wanted out. They couldn't find another partner, and that clinic shut down. So you can see there's when you're just looking at the balance sheet, still these clinics can have a tough challenge. Next slide. That's my second to the last one, or it's my last slide. The next. To end on a sort of more positive note, we are still seeing new, actually philanthropically backed initiatives emerging, like the Marcus Institute at Jefferson. We are seeing this amazing exploration inside of the VA and also the DoD. And the side note here from the economics perspective is those are our single payer universes. You know, those are places where, frankly, the decisions are from the demand side rather than the supply side. That's what happens in a more single payer controlled environment. And so that growth and the learning we're getting from the VA are actually in a business model that is quite different from the dominant business model in the volume-based environment. You know, where we are, I think we're going to be on our next frontier really around economics is been pushed forward by the Joint Commission's inclusion of more integrative strategies and the ACP's new guidelines, each of which are pushing us up to this precipice of saying, well, if you want us to, if really non-pharmacologic approaches and integrative approaches are going to be first, then we've got to have payment structures in order to allow our people to go use them. There was a great article in JAMA Network that quoted a physician saying, you know, if you know all of these things can be useful to your patient, but the only thing that's covered is pharma, you're basically painted into a corner, is the beautiful image there. So economically, we're at a very interesting precipice now around pain, in that in the comments to the CDC on their guidelines that came out last year for opioid prescribing, the AMA, the anesthesiologists, the American Pain Society, California Medical Board, and others all called out these issues and said it's all well and good to name non-pharma, but if we don't have coverage, we are not going to be doing it. And so there are issues percolating here and there. There are pilots in Vermont, in Rhode Island, the one I talked to you about, in Oregon and elsewhere that are examining this. And I would just say that the last thing here is what we were seeing, what I saw in a big way the last time I was with Duke, is we are seeing increasingly these embedded models, where instead of just looking at complementary integrative practices as a separate cost that's out on the side, there's an effort to say, you know, in order to fulfill our mission, there are ways to better and more deeply bring these practitioners into the dialogue, these therapies into the offerings, so we can actually meet our mission of providing better care and figure out how to work the dollars to make it so. That's the end of my presentation. Thank you very much.
Thanks, John, for that presentation. As a reminder, you can ask a question through your Q&A section of your attendee control panel on your screen. Our first question is about to describe behavioral health ties into integrated care. Models exist now where psychologists are consulting with physicians in an integrative care model. They're part of the team and housed in the medical offices. Can you describe how this ties into integrated care?
So I'm not sure I fully get it. But one of the ways that medicine is being integrated, and it's a very good step, is to be much more integrating behavioral health into regular medicine, bringing physical therapists, bringing physical therapy into regular medicine more. So, I mean, I know this is going on in community medicine in a big way in federally qualified health centers. We actually just published something through the Journal of Alternative and Complementary Medicine on it's naturopathic doctor-based model for behavioral change. So I don't know. I mean, it's an interesting concept for people who have been tied to the definitions of integrative that go into the kinds of practitioners who weren't already, in some respects, part of regular medicine, like acupuncture, naturopathy, chiropractic, massage therapy. But it's certainly a direction that we need to go, whether the behavioral health is coming through, a mindfulness-based yoga therapist or through a psychologist. We're stepping in the right direction. I don't know on the business side with psychiatrists and psychologists, except there are typically benefits and Congress's mandated benefits.
Okay. And with the move to a value-based payment model, how can integrative health and medicine programs demonstrate greater value to health systems?
Well, I would invite you to go to the Project for Integrative Health and the Triple Aim website. I think that ACIH's site is integrativehealth.org, and if you go to projects, there'll be a link there, because there's a lot of examples there of research papers that have either aggregated or reporting out the positive impact of integrative strategies on patient engagement, on patient experience. Systems get measured on the patient's experience, and so you can nudge those measurements. But then also, if you look at the cost data that we aggregated there, again, we put those together in order to give, frankly, information to people like whoever asked this, who are trying to make the case, is to bring into one place a lot of the data and studies that help make the case. I would say, more specifically that, think about, what's your area of most interest? Do you have, insights into, autoimmune diseases? Is it around cardiology? And then go study up on where their issues are and figure out where you might be able to help, bend the cost cycle, help get people out of the hospital quicker if they're on a value-based thing. One area where I think there's a great deal of potential is the business of keeping people from readmits. I've always felt there's a strong, in many respects, what's being done is some form of it's an integrative strategy as soon as you talk about a handoff instead of a discharge. But to build out that integrative strategy to maximally help people not need to be readmitted is a significant value that can be created.
Okay. Our next question, can you comment on the use of shared medical appointments in an integrative health clinic?
Whether you're looking at group visits, shared medical appointments, there's group acupuncture visits. I think that group visits have a special relationship to integrative health philosophy and practice. I think that if all of us live by what we say we're trying to do in terms of empowering people, we'll recognize that adults tend to work better in groups and interactive ways. So I think that from the economic perspective, there are cost issues about the direct coverage of groups. I think that there are some models that are, Glenn Sabin has done an investigation of this at Fawn Consulting. And if you go over there and search, you'll probably find some work. But I know there's some workarounds that people are using where you come into a group and are pulled aside for a short visit, which gives you a chance to bill for the short visit. So we've got some challenges there, but again, it would serve all the parties to figure out some good better payment models for this.
Okay, and our last question, what are the main elements of integrative medicine that are most visible or popular to the patient? For example, yoga, acupuncture, or mindfulness.
I mean, if you look back to the studies that have come out of NCCIH and looking at patient use, it kind of goes natural products, massage, yoga. Somebody correct me. Acupuncture is just not that available to a lot of folks, and it hasn't had that much uptake yet. Naturopathic doctors and integrative medical doctors, in fact, are not that available to everybody yet. Chiropractic always, shows up as with a significant, 7 to 10% of people using. If you look at all the value of mindfulness practice, there are few people who don't use some version of them. It's a hard question to answer.
Okay. Well, John, I think I speak for all of our attendees, and thank you for your presentation today. It was very informative. A recording of this webinar will be on the Leadership Program website. The web address is available on your screen right now. If you have any questions about the Leadership Program, please feel free to contact Program Manager Damian Galena. His email address is available on your screen at this moment. And please, I would encourage everyone that's interested to apply by June 1st, and the application fee will be waived. Thank you all for your attention and for attending today's webinar, and we look forward to engaging with you in the future.